We'll invite the next panel up, Drs. Borger, Khoury, Tirone David, Pat McCarthy.
We're just having one simple one because we've only got 10 minutes to go. We'll save the more complex one for December at the Mitral Conclave. We've got a really nice one, but I'm going to get the same panel back then. But this one will be interesting just because it's a nice way to go into a break after all the work we all have just done and listened to. So let me show you a patient I saw 2 weeks ago. She's 87. She had a mitral valve repair in 2006 for severe MR, and she had a P2 triangular resection, annular application, 24 IMR ring. And that was Pat and I. That goes way back, eh, Pat? Back then we didn't know any better. Look, 24 IMR ring. This is a tiny ring. Fortunately, she's tiny, but it was a tiny ring. And then an MC3. How's that for the oldie oldies? Check this out. I still have the video. 2006. Too aggressive a resection. I didn't know any better. Too big a resection, not necessary. Should have been oval at the margin for the calcium, not to the annulus. Annular application, that's the way we all learned. At least that's what we were doing back then, working with Carpentier. So we've done an annular application, very small valve. We put a 26 physio in. I've overcorrected. I took out too much tissue. I've closed it too deeply. And there we switched the ring to that's how committed we were to repair. The 26 physio didn't work, so we went to a 24 IMR. A lot of mistakes. That's 20 years ago. Like none of that we would do today. Having said that, her echo actually was remarkable. They don't note the gradients if the mean's less than 5, so she didn't have a significant gradient. She had minimal MR. And she did well for 18 years. She disappeared until she showed up in our office a couple of weeks ago. She had new onset AF and had a cardioversion, and then she's now got a mean gradient of 10, not surprisingly. And she looks like she's 75. I mean, she's just getting ready to I think she just had her 87th birthday like a week ago or 2 weeks ago. Very active, living independently, going to Broadway, traveling, but 87. Now with AF, now with a very high gradient. Here's her echo. I mean, she really doesn't have an orifice. It's just minuscule. PA pressures are in the 60s. So severe MS, medically controlled. Heart rate was only 69. Mild to moderate TR, pulmonary pressures in the 60s. Obviously, he's going to have a small normal ventricle. Peak and the top PA pressure is 62. So let me ask you guys that. What do we do with her? Tirone?
Well, I need a coronary angiography. Coronary angiography, and then take to the operating room.
Okay, this is going to be, I'm like so happy because I'm still trying to make up my mind what to do here. Keep going, then I'll tell you what I thought. Okay, Michael. She's 87.
At least when I was here in Canada, we would say you give that lady a handshake and send her home and say, you made it this far. But in Germany, we like to do procedures. The hospital makes money, and we would definitely operate on this lady. I know in the U.S., she would probably also get an operation, and I think it's okay, you know, as long as she really is fit and she really is suffering from symptoms. These are really, really tough mitral valve repairs to do. I'm impressed that you got this result to begin with. The small anterior leaflet combined with mitral valve prolapse, watch out. That's a tricky one. And I always say to my young surgeons, if they have that on their case, we put it to one of the more experienced surgeons. Short anterior leaflet, tough valve to repair. You just don't have any reserve. You don't have any room to make a mistake.
Which I did on that case. I got away with it, but left her with the setup for stenosis. It's amazing she got 18 years. Pat?
So really tough. So, you know, and ultimately you have to treat the patient and not treat the echo. And it sounds like she feels pretty well and she's pretty active. So I wouldn't rush into doing anything that may kill her, trying to make her better. Without seeing her, I mean, this is one where you want to lay eyes on her.
Yeah, she really passes the eyeball test.
She's good. She's not an 80-pound,
I mean, she's really
frail
good.
lady.
No way. And
within
she,
her-
by the way, just to give you some color, Pat,
So her-
she says, I'm living to be 100. I'm not letting this take me out. Please do surgery on me.
Well, then, a prom for replacement in an 87-year-old redo like that is probably about 5%, something like that is what I'd be thinking. I don't think you're going to be able to re-repair that. I don't think I would really
No.
try, because you don't want to repair failure in a year, and now you've got a third-time redo. So I would, and you don't have much tissue most commonly, because you resected a lot at the first one. So I would also, though, we just poached Anita Asgar from Canada, and brought her down to Northwestern. So I'd ask a really good interventionalist, do they have any options for a patient like that?
Yeah, there's really nothing. Complete tiny ring. Gebrine?
Myself, I'm very sensitive to ladies, so I will not hesitate to take her back.
Gebrine, I have a different question for you. Would you have let her go home to think about it, or would you have admitted her or operated her tomorrow?
So, but the first thing I will do when in the OR is take out the ring, and I think I will be not surprised that we don't need any more thing, and really only take the ring out. Maybe we'll cure the stenosis with some, because we have a lot of pannus with the ring. If you take the ring and clean the pannus, maybe we'll cure the.
I don't disagree. I mean, it's not something I really thought about when I saw her, but now that you mention it, I've shown cases like that where you take a small ring out and get rid of free the hinge point from the fibrosis, and they actually
We'll cure the patient,
do
yeah.
okay. All right, guys, quickly, Joe, what do you and Mark think? I got to hear from everybody. Because she's 87, I want to make a good decision for her.
Yeah, I mean, you've described a really, really good-looking 87-year-old.
She's really good.
Yeah, so I think in the hands of an expert center, the morbidity and mortality will probably be reasonable, very reasonable, and she has severe MS. I'd operate.
Mark?
I'd offer her surgery, but I would remind her that very few people die from MS, and some people do die from heart surgery.
Yeah.
So, but if she really wants it,
Yeah, absolutely.
Dave, we published this some 10 years ago. One of the complications of mitral valve repair for a prolapse, it is mitral stenosis. It's uncommon, but almost invariably, it's not because you put a ring at 26 or 24, it's because of pannus. Frequently, you can go back in 10, 20 years later, remove the ring, and peel off all the, and leave the patient no annuloplasty. We have now enough cases to put another paper on outcomes of those cases. In other words, remove the ring, remove the pannus, leave the mitral valve alone. It doesn't seem to redilate the annulus.
And I will tell you guys, that we'll see this case tomorrow. We'll see some videos tomorrow morning when we're having our breakfast session about mitral valve replacement. 24 ring, you must use a modern prosthesis that everts so you can have it sit superannular and then let the struts open, because you'll never get a sizer in this hole if you're trying to do replacements. We'll talk some more about that tomorrow. Ani, you were going to say something.
No, I just wanted to ask the audience, for the surgeons in the audience, how many of you would operate on this patient? Can you just put up your hand, surgeons? And how many of you would not, for surgeons? So everyone else is not a surgeon? You know, I just think though we have to, bring this case down to reality. I know all my colleagues here, that's why they're here for this session. They're the master surgeons, best surgeons in the world. But the reality cannot be for an 87-year-old with mitral stenosis, previous surgery, that they're going for a reoperation. Like we say, like it's easy. And this PROM we're talking about, I bet you if this patient has surgery in the United States, 100 of them, maybe 80 would survive on a good day. It's not 5% in North America, or even in the world, anywhere in the world. I think we have to be realistic with the patients.
Yes, supposedly the United States is 10% for replacement. And so I think by the way, I asked you guys and I didn't really finish. What were your all's estimated? When I saw her, by the way, I thought her risk of mortality, I told her her risk of mortality in surgery is probably 3 or 4%. I don't know, something like that. No more than that. Everything else works normally. She's obviously very fit.
I just
She's
think
in good shape.
that calculator's averaging all the centers across the country, and I don't think that's the way we should be thinking about that.
Yeah, well, I'm bringing that up, and
But Joe, all those centers are centers like yours, because the average surgeon is not going to operate on this patient. So that 10% actually reflects, top surgeons who are used to doing redos. So that's close to reality, I suspect.
Well, I would disagree. I think the bucket list a lot of patients get put in the bucket over 65 or 70, and you're right, there aren't many patients that are 87 in that list in general. That's number one. But number two, this just calls out, and I'm just going to make a plea to every Canadian center and leader that's here. Please learn about this ATS AQG program. The algorithm that Blackstone and colleagues developed lets us do the assessment for individual patients, not rely on this old bucket list of things like this, because I don't think these numbers are correct, and they don't reflect what's happening in our center today. And I really want to know what happens in my center, not what happens under Tyrone's guidance when I'm trying to guide a patient. So we really do need to get into modern risk assessment, because that's why I looked at these numbers. The case I won't show you, but we'll show it in December because we don't have time.
David, while we have this up, can I point out another thing? A lot of 87-year-olds are not that worried about death. They're worried about all those morbidities. She has a stroke, that's 3.4%, renal failure, 20% risk of prolonged ventilation. So we shouldn't, just minimize it down to, well, either you survive or you don't, because she may be worse afterwards. Because she's pretty asymptomatic.
Pat, I couldn't agree more, but this gets back to the fallacy, I believe, of this system. Because, for instance, stroke, they tell me the stroke rate's 3%. Are they scanning every patient head to toe? Are they using TE routinely in every patient? Are they responding to what they find on these things? Do they back out if they find an aorta full of junk and not do that patient because they're not going to take the increased risk? So this data is so homogenized, I don't know how we can make a real proper calculation just looking at this PROM thing on a calculator. We have got to get in the 21st century doing this. Mark, you can have the last comment. How about that?
Excellent.
Morale will stay on time.
Well, what we have to realize is that this equation was calculated or developed with multivariate analysis, right? There's probably 0 87-year-olds that had a redo MVR that were in this calculation. There's a certain percentage for 87, there's a certain percentage for redo. So I don't think it's applicable to any 87-year-old redo.
Yeah, unfortunately, the case I can't show you because we don't have time, but we'll get to it one day, is someone that was in his 60s who was having his 6th operation. It was an aside topic. His 6th operation for valve disease, and he has an STS of 1.3. How is that possible? Your 6-time redo in 900 hospitals in America, and your risk is 1.34. But that's for a different day. Del Plant, leave with that seed that we got to get better at risk calculation, learn about this AQG program. I'm really glad I got to present this case. When I saw her, I will tell you, I didn't know what to do with her. I actually told her I was coming to Toronto. I would put her case together and show her to a bunch of my friends that know more than I do. I really did. because my gut reaction was Tyrone's. This lady needs surgery. She looks like she's gonna outlive me. My gosh, I know, I wish my brain would work like that when I'm 87. But then I really think about just what Pat said, like, should we just give her another, is her wrist really gonna change this year or next year? Why not let her go make a few more trips and enjoy life a little bit and just follow her closely and just not, make her really make the decision. Let her sit, and that's how I sort of left it, but I said I'd promise to show this panel this patient.
But like Tyrone used to say all the time, was there, there's redos and there's redos. She was operated on by you, right?
Yeah, 20 years ago.
And so you assume there's very few adhesions. For Tyrone's redos, there were no adhesions. It was like a first-time operation.
But that's because Tyrone touched them.
I'm trying, I'm trying to be a bit funny, but it's true. If you follow a good surgeon, the redos are not as difficult as following somebody who, really struggled, like the case you showed
Well,
before.
back then, I will say I had Ani and Joe Chickwee open and enclose it and help me with all of them. So I promise they were closed very thoughtfully about the redo one day. Okay, listen, we'll stop there. Thanks so much for your attention. Okay.